colleagues. First of all, thank you, all of you, for this kind invitation. I'm really happy to be here in India again after a while, and it is my very first time in New Delhi, and so far I really enjoyed that. So if the question is what is new in 3D Echo, I have to say that there is a lot, and I will try to summarize in 4 broad chapters. First of all, there are a lot more in the quantitation, so we can use 3D Echo for quantitation, as Dr. Rakesh has already alluded to that. Then we have a better algorithm for the volume rendering to provide more anatomically sound images of the cardiac structures. We have new ways of display the structures, not anymore just on monitor, but we have other options, and we can really print those data sets in order to have real objects in our hands, or we can use the augmented reality or the virtual reality to interact with 3D data sets. And then there is an extension of the fusion imaging to help in the catheterization during structural interventions. Starting from the chapter of the quantitation, all the times where we had to acquire multi-bit data set with the possibility of stitching artifacts and investment of time are definitely gone. Today, all major vendors of echocardiography have developed new probes that allows the acquisition of a full volume, even a larger full volume as those for quantitating the left ventricle in a single beat. So we can use the 3D probe exactly as we are used to do the two-dimensional. But this is not just that, there is more, because from these data sets we derive not only the volumes and the ejection fraction of the left ventricle. In this case is a solution proposed by Philips. There is also the left atrium that are automatically detected without any interaction with the operators. Everything is based on the artificial intelligence, but now we can also have the measurements, the actual measurements of the left ventricular mass from the same data set, so we don't have to calculate it based on elusive geometrical assumptions, but it's true measurements, just as the difference by subtracting from the epicardial volume in blue the endocardial volume in purple, and then multiplying for the specific weight of the myocardium, 1.55. And as I said before, there is also the quantitation of the left atrium, and this is becoming more and more important. The diagnostic and prognostic role of the left ventricular volumes, but also left ventricular function, is increasingly recognized. Not only the maximal volume of the left atrium, but even more important is the minimum volume, and for sure the function, and particularly the ejection function of the ventricle. This is again the solution by Philips. GE has its own solution. Both of them are fully automated, so they don't require major interactions by the operator and are very quick. And in addition, with the GE, not only we have the volumes and the function derived by the volumes, but we have also the 3D strain that is both longitudinal and circumferential, and the strain of the left atrium has become more and more important, particularly in the diagnosis of left ventricular diastolic dysfunction and in the assessment of the prognosis of patients with heart failure and preserved ejection fraction. Moving from the left side to the right, something that is not possible with any of the two-dimensional echo techniques. There is no way of calculating the volumes reliably calculating the volumes of the right ventricle. Now you have the possibility to do it on board on your 3D echo machine, to have a semi-automated software that provides you volume and ejection fraction of the right ventricle. And for those of you that are following the scientific literature in echocardiography, have seen in the last 10 years the growing numbers of papers dealing with the right side of the heart, right ventricle, tricuspid valve, right atrium. This is simply because now we have the tools to effectively quantitate and trying to understand. However, all these softwares, as you have seen, are different from the different companies, and some companies have certain softwares, other companies have others. So today, to cover the whole portfolio of possibilities in 3D echo, usually we have in our lab a machine from different vendors, and this is really a headache, because each one of those vendors has its own software, its own workflow, and it's very difficult or time-consuming being fully conversant with all those software. Luckily, something is moving also in this direction. Recently, we have established a joint task force together the European Association of Cardiovascular Imaging and the American Society of Echocardiography. I have the privilege to chair this task force together with Roberto Lang and Jim Thomas. And this task force brought together all the industry vendors in order to provide a way to exchange the data sets. And last month in Portland, during the American Society of Echo, for the first time, the different vendors came and demonstrated the possibility of sharing the dataset. That means that any dataset can be seen with the software you have in your lab. For example, if you are a GE user and you have EchoPack, you will be able to read also Philips, Siemens or Toshiba, and vice versa, and so without having the need of buying and learning to use many of those datasets. From quantitation, we move to volume rendering. Now we have a really powerful algorithm in order to render in a more realistic way the actual anatomy and the functional anatomy of the heart. On the left, you can see the endocardial surface of the left ventricle in a healthy subject. You see the hypertrophied trabeculae in hypertensive heart disease, very realistic, and this is the deep trabeculae that we have in a non-compaction left ventricle. So we can really see the anatomy of the cardiac structures. And in terms of improving the way of displaying the structure, this is the very last release by Philips. This TrueView is sort of trans-illuminations of the data sets that improve the detection of the disease. For example, look how effectively you can see this huge myxoma with the trans-illumination compared to the old ways of showing the anatomy with the volume rendering. Finally, there is an effort also from the industry to help the echocardiographers to get oriented in these 3D datasets in order to provide the markers that make anatomical orientation much easier. You can have a number of those markers of different colors. You can put the markers on the cardiac structure, and when you rotate the data sets, the markers always follows their rotation. This is useful in the cath lab during interventional cardiology. This is absolutely welcome for pediatric cardiologists and all those that have to deal with the complex congenital heart diseases where the anatomy is really very, very complex. We have also new display options. You all know the possibility about printing the 3D dataset in order to produce real objects that you can measure, you can manipulate, and for example, the valves, the tricuspid valve, the mitral valve, the left atrial appendage, and so on. What is new that now this dataset can be displayed in holographic for the augmented reality with the HoloLens. This will provide a completely new way of looking at the dataset, but also to interact with these datasets. And so surgeons or fellows can try surgical procedure, interventional procedures, and can rotate, measure, and change those datasets. And finally, the last words are about fusion imaging. We all know the fact that there is the possibility of fusing fluoroscopy with the 3D echo. This is done routinely in the cath lab during procedure. What is new today is the possibility to have on your echo machine the CT fused with the 3D echo. And so you can put together the broader view of a CT with the anatomical and functional detail of a 3D echo. This can be on your machine and can also be projected on the screen of the interventional cardiologist during procedures. Here you see, for example, the use in assessing the mitral valve, and you see the green area is the field of view of a 3D echo that is much smaller than the big anatomical display of a CT. With the CT we can nicely appreciate the extension of the calcification at the level of the annulus, while with the 3D echo we can see the anatomy, and particularly the functional anatomy. So this is really important, putting together the tissue characterization, the wide field of view together with the anatomy. But our echo machine is becoming more and more complex, because on the echo machine, when you are in the cath lab, you can have the live X-ray, so you can follow what is the interventional cardiologist is doing. You are not blind anymore, or what is happening on in the patient. You have the CT with all the planning information, the measurements that has been taken before, and you have the live echo, and this will bring additional information in the cath lab. For example, during guiding procedure, this is an example of a puncture of the interatrial septum. So just to conclude, as you have seen, there are a lot that it's coming, and it's already come in our echo lab. So we have a full portfolio of quantitative tools that allows a complete report. We can assess the left ventricle, the right ventricle, the mitral valve, the tricuspid valve is coming, and both the atria. We have new ways of display the anatomy in the volume rendering, particularly with the transit illumination. Holography is very promising, not only to visualize the dataset, but to interact with the dataset, and now extended fusion imaging is available on board of the echo machine to make the life of the echocardiographer and the interventional cardiologist easier if you want. If you like 3D echo, if you wanted to see more new to come, next September in Padua, where I come from in Italy, there will be 3D echo 360, all the echo experts from all over the world will gather to exchange their experience and the news. And as I usually say, if you are not interested in 3D echo, you can come to Padua anyway with your wife, your girlfriend, your husband. Padua is just 20 minutes from Venice, that is the most romantic city in the world. Thank you very much for your kind attention.
Dr. Louis Badano says you can come with a girlfriend and a wife. Please don't take them together. That'll be Wistfotak.
Dr. Badano,
Yeah.
I really compliment you from the core of my heart. And I'm really motivated by your last slide, a textbook on 3D echo.
I am.
That's a very beautiful work which you've done. People are in the learning phase and you have come with a textbook of echocardiogram. I just like to know one thing from you. You mentioned about the super specialization of 3D echo to find the texture of the myocardium, to understand more of anatomy. You think, does it really help us to understand the hemodynamics better, or there is no benefit of 3D echo so far as the cardiac hemodynamics are concerned as compared to other modalities of echo?
Thank you very much. Thank you for the textbook. This has been a huge effort together with Roberto and Denisa. This summarizes 20 years of work in 3D echo for our labs. About your question, I say yes. And the reason why I say yes without no doubt is because with the 3D echo, we are just measuring. We measure the volumes, we measure the areas. Now we are measuring the flow, and we are not calculating anymore. Calculating implies geometrical assumptions about the shape of the orifice, the shape of the chambers, the shape of the flow and the jets. We can, and these assumptions may be valid in some patients, but are not valid in most of the patients. Being able to measure without any pre-assumptions about the shape is the step forward that we have with 3D echo.
Dr. Badano, I think you mentioned one more thing, 3D echo strain rate.
Okay.
You think in what way you find it's much superior, beneficial as compared to what we do by 2D?
Yes, theoretically, 3D echo is superior to the echocardiography, because with the 2D echocardiography, we are just following the motion of the speckle for a certain number of frames. Then the speckles go out of the tomographic plane, and we have to make a mathematical projection of where will be the final destination. With 3D echo, having a three-dimensional structure, we can follow the speckles in all the trajectory, so we can measure again instead of calculating. In reality, the technology is not mature enough, and all the comparisons that have been done, we have seen that despite the theoretical superiority of 3D echo, but in clinical routine, 2D echo is still the winner at the moment.
Do you find that the stiffness, people talk a lot about LA stiffness or a left ventricular stiffness now, does it really help us in prognosticating the patient, or does it really help in the therapeutic implications?
This is the hope for the future, because this is really new, as is not a 3D echo technique. It uses ultra fast probes to acquire images at 1,500 frames per second to look at this stiffness of the myocardium. So far, it's feasible in a really small area, just the interventricular septum, but it's very promising, because this seems really to be the way we will look at the tissue characterization using ultrasounds.
Just the last question, sir.
Yeah,
it's
please.
really from my heart. The question is, when you talk of longitudinal strain rate or radial strain rate or circumferential strain rate, Do you think the future is where we are going to classify the diastolic heart failure based on which fibers are involved? Or do you think there is no possibility of classifying the heart failure on this strain rate?
So far, what we know is that the strain of the atrium and not of the ventricle is really useful not only to make a correct diagnosis of diastolic heart failure, particularly in the group we have an indeterminate diastolic dysfunction, but also to provide an added prognostic value in patients with heart failure and preserved ejection fraction. Those of the patients that have a reduced strain of the atrium are the patients that will have more events during the follow-up.
Thank you very much, Dr. Badana. I
Welcome.
think it's open for suggestions, comments, any interaction. Anyone? Sandeep? Anybody? Excluding Rakesh. Anyone?
While all this is very futuristic, and the HoloLens project appears to be, like a dream for the future. But how practical is it going to be to think of function assessment on 3D integration with the HoloLens? Or, for example, I think the first step is for novices like us to start recognizing three-dimensional images, which is creating the data set and recognizing, which is something we are not able to do. So I would really appreciate if you would, tell us how we can change from our understanding of a two-dimensional data set into a three-dimensional data set. How do we train our eyes and mind? Because I think that's where the biggest challenge is.
So I will start from the last question, how you can become confident with the 3D echo. I would say just start. If you start and you will be able to see and understand the anatomy, it's like the drug. You will become addicted and you cannot do without.
Dr. Badana, there are two issues here also. One is, of course, they're not scientific, but one issue is of the cost involved, and the second issue is of the time involved. Because we are all practical physicians sitting here who would like to use an imaging modality to get enough information from it to plan our therapy, perform our therapy, and then hope for better results. So the costs, the practicality of both the finances and the time involved
Okay.
are to be kept in mind.
Use the word finances. Finances.
Yes, how long it will take to characterize left ventricular function? How long it will take with the 2D echo?
I see those brilliant three-dimensional
Yeah.
sets that you showed, but and like I said, we are novices, so we
Yeah.
can't appear to get them in a single frame, and to have the equipment which would be able to get them in a single frame collection,
You
I
will.
think are beyond our reach for most.
If you will try, you will. And in terms of and in times of cost, if you want to fully characterize the left ventricle in your patients with hypertension, you have to acquire 3 apical views for chamber to chamber and apical long axis in order to have the volume, to have the mass, and to assess the strain. And this will require a lot of time. I can do that with just one single acquisition, 3D in a single bit, and all of that will become completely automatic. So, in addition to be quicker, I will also be more reproducible than you that are continuing to tracing by your hand. This is the involvement in terms of times and cost. And about the HoloLens, I would say that if you think broader, there are, for example, pediatric surgeons that don't have the possibility to train on rare congenital abnormalities. we need just one good data set of one of them, and we can train thousands of cardiac surgeons, because all of them will be trained with the same heart that will be reproduced more and more. And this has enormous implications in terms of how we will teach, and also how we will teach the anatomy.
We know that Philips is working with Microsoft for HoloLens. What about the other vendors? Are they also working with somebody on
Everyone is working on this. If you just pronounce the magic words, artificial intelligence and augmented reality, everyone is working on that. It's like sex in the teenagers. Everyone is talking about that.
Thank you, Dr.
No
Madana.
one is doing that.
Thank you. I think it was a brilliant exposition. Let's see what Rakesh has to say. Rakesh.
Can I add one thing? Believe my words, is truly an addiction. The day you start doing 3 dimension cycle, you'll forget about 2 dimension.